recognize is a living, breathing document, and we fully recognize that there will be numerous instances throughout the years that we will need to make modifications and adjustments to be flexible to the changes that are ongoing in the community. Joe's probably going to speak a little bit in more detail about the ongoing supervision, but as you know, it's 2 states that have to actively supervise. And from the very beginning, we determined that there needed to be close contact, communication, and coordination between our states. So we entered into a memorandum of understanding between the 2 states. We have weekly phone calls, and during the application process, we actually had a couple of meetings together in determining where we were going with the application process. In terms of the performance, what I can tell you right now is it's too soon to tell. We've only been in effect for 16 months. Most of what has been happening during this 16-month time period has been processes, trying to get processes in place. Now, from that perspective, that's been very successful as far as we're concerned. There have been some issues. There have been some hiccups. There has been a report that's been issued by the COPA Monitor and by the Department of Health, both of which are available on the Department of Health's website. Those reports reflect that, yes, for where we are and for what can be accomplished in 16 months, things have gone well. There's always room for improvement, and I think the real test of how effective this COPA is going to be probably not beginning until years 3, 4, 5, when we're starting to see the effects of those processes, how effectively they have been implemented, and are they producing the results that we're hoping that they will produce. Joe?
Great. Well, thank you, and good afternoon, everyone. My name is Joe Hilbert. I'm the Deputy Commissioner for Governmental and Regulatory Affairs at the Virginia Department of Health. And I, too, have been living this for the last 4 years. And I also wish that I had the benefit of attending this type of conference about 4 or 5 years ago. It was very
Really?
So, but like Janet said, we had a whole big, long approval process that we went through, working with Tennessee, as she indicated. We also worked with our Southwest Virginia Health Authority, which was an established entity in Virginia, and the cooperative agreement statute that was passed by the General Assembly in 2015 gave the Southwest Virginia Health Authority an initial review role in any application that would be filed, and they did review the application and make a recommendation of approval to the Commissioner. In terms of the active supervision framework, we are still at work with Tennessee, with Ballard, on developing, finalizing, fleshing out what we're calling an active supervision framework for the cooperative agreement. The approval of the cooperative agreement in Virginia we have a different instrument than, we don't have a terms of certification like Tennessee has. The commissioner rather issued an order and attached to it 49 conditions that have to be met throughout. Those conditions included the requirement that Ballard submit to the Health Department to Virginia a series of plans. A plan for population health, a plan for children's health, rural health, behavioral health, regional health information exchange, and health research and graduate medical education. So those plans have been submitted. Most of them have been approved. A couple we're still working to approve. One of the important things for me is that each of those plans contains strategies that are really aimed at overall at improving the health status of Southwest Virginia, Northeast Tennessee, Ballard service areas, so 31 strategies in all. So we have all these strategies. So a big part of the active supervision framework is intended to give the State Health Commissioner in Virginia a clear line of sight as to the extent to which, whether in fact these strategies are being implemented as Ballard said that they would be. So that's a big part of what we're after. The active supervision framework contains a series of metrics, different measures, and I would summarize these by saying that it's a combination of long-term outcome metrics designed to get at answering the question, is the health status in Southwest Virginia improving? Because again, this is a region that has long defied attempts to improve the health of the population. We all know how important that is. And then another series of metrics that are really more short-term or intermediate in nature, and they're really more process or output metrics. So we don't want to have a situation, a framework, where we simply have a series of outcome measures that are long-term in nature, and we don't find out until too late that the strategies haven't been implemented in such a way to really affect those outcomes in a meaningful way. So coming up with an additional series of intermediate, short-term process and output metrics is also part of the framework. Our active supervision framework is also built around an envisioned series of deep dive meetings and lighter dive meetings with Ballard, whereby we go through all of the metrics and identify areas for improvement, what's working well, what's not working well. We had our first deep dive meeting on May 15th down in Johnson City, Tennessee. So that cycle of meetings is built into the active supervision framework as well. Let's say one challenge that we've encountered so far in implementing an active supervision framework has been identifying appropriate measures and data sources and establishing baselines for these various metrics. And again, as well as ensuring that all of those 31 strategies across Ballard's 6 plans have clearly defined process and output metrics that can be looked at in the short and intermediate term, so that we really have confidence in Virginia that they are doing what they said they would do. To address that ongoing challenge, we have established a metrics work group with Ballard and with Tennessee that will begin work this summer to identify, to address certain gaps in metrics that we've identified over the past 16 months. We are required to have in Virginia a technical advisory panel that reports to the commissioner whose job it is to recommend metrics and revise metrics to the commissioner. So our plan of action is for this metrics work group to work over the summer to bring recommendations to our technical advisory panel, which will meet in November. Technical advisory panel will consider the work of the metrics work group and then make its own recommendations to the commissioner for final action. In terms of how we've structured ourselves to do this, we have brought on a number of staff. We have staff in our commissioner's office in our Office of Licensure and Certification, and in our Population Health unit within the department, all contributing to our staff work on this. We also have assistance from our Department of Medical Assistance Services, which administers the Medicaid program. We also are coordinating with the Southwest Virginia Health Authority. We are working to finalize a memorandum of understanding with that group so that they will, with the intention of that authority serving as our local advisory council in Southwest Virginia. So that, again, that local input's very important. In terms of just some initial observations on Ballard's performance over the past 16 months, I would concur with Janet's comments that it is too soon to tell in terms of substance. Certainly, this is a big merger. It's my observation, it's our observation, that Ballard has a lot of balls in the air right now. They're juggling a lot of things. So again, those process and output metrics are that, can they actually pull this off? Can they actually do what they said they wanted to do? Can they deliver on what they promised? I would say that Ballard's work to stand up the accountable care community in Southwest Virginia has been very impressive to date, but again, a lot more work to do there. We're looking for results on the population health outcomes for the region. I guess the only other thing I would say, just in the way of opening remarks, is one of the benefits to the COPA that we hope to see is improvement in the health status of the people in the region across many, many dimensions. Again, this is a part of our state that unfortunately, over an extended period of time, has demonstrated really pretty poor health outcomes across a number of metrics, and that's not in anybody's best interest, certainly not in the state's interest. If we're looking to control healthcare costs, we want to take an upstream approach here. It's easier to keep healthy people healthy later in life than it is to try and turn around someone who's got many, many comorbid conditions going on at the same time. So we expect Ballard to be the leader in Southwest Virginia and Northeast Tennessee. You were supposed to say that. This is something that they can farm out. They can't contract this away. They have to be the leader. That's our expectation.
Well, thank you, Joe and Janet. Next, we'll have Dick, if you could pass this down, as the legal counsel to Ballard Health. Can you describe Ballard's experiences since the COPA and cooperative agreement were approved, and what efforts has Ballard had to implement the COPA and comply with the state's terms and conditions that Joe and Janet just discussed? And if you can, what challenges has Ballard faced and what successes has Ballard achieved so far?
Well, I have a lot to cover in 6 minutes. This is actually a 6-year story for me. I was board counsel to Wellmont, which began a strategic options study. Basically, if they did nothing, they could sustain their existence but couldn't improve anything much of anywhere. They went through an RFP process, decided they didn't want to sell to a for-profit and have just investor-owns making healthcare decisions. And their choice was to be either an outpost for a super-regional nonprofit or as what had been their arch rival said, why don't we do something nobody's ever done before? And it was an unexpected offer from Mountain States, but one that quickly got to the core of why people serve on health system boards and why they are leaders of any community. Because if we listen to the stories this morning, the story of Ballard is not the story you've heard this morning. The story of Ballard is about the why. It's not about the how. And so I'm going to give you a little bit. I can show pictures faster than I can talk. And to tell you a little bit, for those you know, it is a large nonprofit health system that covers 21 hospitals. It's the only children's hospital in a region. Each of the systems had about $1 billion in revenue, so it was a merger of almost equals. And the last year has been extremely intense, as you can imagine, just merging two organizations of that scale who had been arch rivals for 20 plus years. They treat, almost 500,000 emergency visits. They have 800 other employed professionals. And at 15,000 employees, they are the #1 employer in the region. The #2 employer is Eastman Chemical with 6,000 employees. The university employs 2,500 employees, to give you an idea of the scale of significance, and also the importance of why they decided if they were going to address the core issues, they needed an infrastructure and a leadership structure and a management structure to do it. This area is roughly the size of New Jersey, but it's only 1 million people. The COPA area covers 21 counties in 2 states. The service area would add another 8 or so counties to about a little bit in Arkansas, Kentucky, and a little bit in North Carolina. But this is not the Great Plains. I mean, there's literally a county in here that there's one way in and one way out. And so the ability to kind of serve a lot of micro regions and micro markets, because they've been communities. And of course, one of the real challenges to this region has been how to function regionally. You've got, this is Appalachia. There is a lot of territorial rivalries on a micro scale, but the ability to do what needed to be done next required a different view. This is a little bit about the health status. There are some areas like Washington County where the university is located. That's Johnson City, Tennessee. And to give this perspective, Johnson City, Tennessee is smaller than Billings, Montana, which you heard mentioned in the earlier presentation. So that's the largest community in this market. But it's a university community. It's reasonably healthy. It's young, healthy, vibrant. But they're also, certainly in the more outlying rural areas, you have some of the most difficult health status conditions in the state of Tennessee and very much in the state of Virginia. Health status is the problem. That's the problem. And that became the why about why Ballard was formed. This again shows you about half the hospitals make money, about half lose money, and some of them lose a lot of money. But if you're going to have an ecosystem, you're going to try and keep it all in balance and keep it all rationalized to a regional approach. This is a very significant. This is not light supervision. We've heard the light COPA, and well, this one is 150 pages in Virginia and more, equally number in Tennessee, and it's got all the behavioral covenants you're used to seeing, which really is not the story. And I know that's kind of been the talk of the morning, but the story really here wasn't how do we combine, create some efficiencies and improve our bond rating, or how do we combine and create some efficiencies and get some revenue flow because we can negotiate with our payor. The story here was if we're going to address the health status of our community, where are we going to get the money? And if it's not us, who? And if not now, when? And those are the literal words in a board meeting from the board chair, not from me. And the commitment was we're going to take the money we save from this combination and we're going to attack the problems that are endemic in our community, because only that is going to change the socioeconomics. And this became there is no COPA like this anywhere in America. Nothing even close. And it's not about the active supervision, and we are actively supervised, and I think we've had a very professional relationship, but we talk to the state daily. The COPA monitor comes and spends 3 days a month. That's a month a year looking at things, and being the Attorney General and the Commissioner of Health come to board meetings twice a year. The Commissioner of Health in Tennessee is one of the child abuse specialists. She's a child maternal health specialist. She knows what's going on here. She ran rural hospitals in West Tennessee. We are all trying to do something that's never been done, and we're trying hard, but we have no misunderstanding. This is hard. It will be difficult. We are accountable, and we are being supervised. Here's what we said we will do, and we've been presenting the last 15 months, that we've kind of been active for 15 months. We've got an $85 million investment towards behavioral health, which includes, by the way, getting telemedicine into the schools. We've got telemedicine, behavioral health into schools already. The big problem in behavioral health was not we need a new psych hospital. It's we don't have any mental health professionals. It's the same problem the military faces. until we recruit health professionals, and the marketplace doesn't do that. Somebody's got to recruit them, and it takes an infrastructure to do it. The next was on academics and research. The public health program for Tennessee is at East Tennessee State University. Vanderbilt, for example, is a rock star medical school. It trains no primary care physicians, none. ETSU, that's what they do. So beefing up that training program and focusing on population health, focusing on primary care. Population health needs, Robert Wood Johnson says, you know, of the major indicia of population health, we're bad in almost all of them. And it is what you would think it is. It's the opioid crisis, it's ground zero. Obesity, it's in a terrible state. Obesity leads to cardiovascular disease. It's high in smoking. All those things you don't treat in the ED, you've got to treat before they get to the ED, before they get the emergency. How are you going to do it? So these are some of the different areas. We develop plans, strategies, milestones, accountability. We've submitted them to states. They're not even fully approved yet, but they're very comprehensive plans, and I think you should be impressed, and I encourage you to see them. Again, Children's Services has been another one. It's the only children's hospital, but it's still a challenge. Nashville has 2.5 million people, has one children's hospital. Memphis has 2 million people, one children's hospital. This area has 1 million people. And they will tell you that's hard to get a full-scale, full-service children's hospital up for 1 million people. You're not going to have a bunch of those. Same thing with Level 1 Trauma Center. You can Google Level 1 Trauma Center. It takes 2 million people. We've got 1 million. We had 3. We had 2 Level 1s 20 miles apart. Cost $1 million just for neurosurgery coverage. And it's the same neurosurgeons covering 2 hospitals. I mean, really? Aren't there some very evident things we can do better and more efficiently? And then the money on health information, we can cover some of this. The key thing here, I think there has been not just we're going to take $300 million and we're going to attack the health status of our community. We also said we're going to create an index to prove we did it. And we've been working with both states to say what are those metrics, and there really are the super metrics. I mean, there's about 70 in our COPA right now, but if you look at one of the key socioeconomic metrics is our children reading at the 3rd grade level when they're in the 3rd grade. And that's an indicator of incarceration. That's an indicator of teenage pregnancy. That's an indicator of a lot of significant things. But when you take 4 measures of kind of, are you ready for kindergarten at kindergarten? Are you ready for the 3rd grade at the 3rd grade? All the things that really make a difference require a community to attack it. It takes an entire community to attack it. And it takes a leadership structure and a management structure and an infrastructure, not just a big grant-making organization, to do it. And that's what's been formed this year. It doesn't exist anywhere in America. 250 organizations who have committed to this plan in all these cities, what Joe just referred to, where they are part of the elements, because yes, Ballard doesn't teach school. They're not going to do what needs to be done in the schools. That's going to have to be done in the schools. You know, there are various elements of this. There's a Healthier Kingsport. There's a lot in the university program. There are a number of the employers the major employers here are almost all self-insured. And so they have to own their piece of it. And getting them to do it is part of getting a plan, getting milestones, and accountability. And I'll close with the fact that to do this, it is a 10-year program. And these are 10-year plans. For example, I think the studies will tell you if you're 50 years old and you're smoking, it's hard to get you to quit smoking. Yes, it can work. But if you bring up children not to smoke, and they've gotten to a certain age, the likelihood of them starting to smoke in large numbers is much smaller. So these programs about what are the early interventions, how do we move those to the next level, on each one of these major indexes, there's a plan, there's a navigation process, and I think that's really a core to what we're doing. And I think it's interesting to say here that this is one of the great population health stories in America. It may be a little confounding from the COPA point of view because COPAs make one, but the problems that have to be addressed here are not going to be addressed in the marketplace in a pricing model. That's not. I mean, pricing models and capitalism got us to the opioid crisis. Now we're going to have to do it. But the ability to deal with those problems takes a different approach, and that's what we're trying to do.
Thank you, Dick. Next, we will hear from market participants who will share their observations of the Ballot Health COPA. From Tennessee, we will hear from Dr. Scott Fowler, representing Holston Medical Group. And from Virginia, we'll hear from John Sire, who's representing Anthem.
Thank you. Good afternoon. My name is Scott Fowler. I'm the president and CEO of Holston Medical Group. I want to thank the FTC and the Office of Policy and Planning for having me here to speak today. I'm delighted to get an opportunity really to speak out about the COPA and sort of give our perspective on what's happening, boots on the ground. Before I do that, I want to talk a little bit about the perspective of Holston Medical Group. So Holston Medical Group is an independent medical group. It's owned by physicians. It's led by physicians. It's dedicated to a patient-first or patient-centric model of care and has been for quite a while. It's been in this Northeast Tennessee, Southwest Virginia region for 42 years. It was started with a Robert Wood Johnson Foundation grant to serve the underserved areas of Appalachia. And I think over the last 42 years, it's really focused on doing that. Today, we manage over a third of the patients in the entire service area. We see about 60,000 patients a month. We're multi-specialty. We're about 70% primary care, but we have 18 different specialties. I am a physician. I'm a partner in HMG, an equal partner with my other partners. I've been the president and CEO for the past 10 years. 10 years ago, as a new CEO, and with the leadership of the board, we had a new opportunity to take stock and reevaluate the future and the plan for how to meet and exceed our mission for our patients in our region. That year, HMG signed its first contract to be paid not on services or volume, but on value and value improvement. Since then, we've succeeded every year in growing that population of patients, driving higher quality and lower cost markets into the region. Now, almost 30% of our revenue that we receive every year is paid in value. HMG wouldn't even be here and couldn't survive on the fee-for-service that's paid in our region without these value-based payments, which are paid on a risk contract and are paid based on how well we perform in terms of both cost control for our patients, but mostly for outcomes. We've scored in the top few percentile nationally year after year and have been part of a community of mostly independent providers in our region, both Southwest Virginia and Tennessee, that have been successful in medical shared savings programs and in building infrastructure that you need for value. Our region is truly exceptional and is recognized nationally. So what did we see 10 years ago when we did our analysis and when I started as COO, which we still see today? It's often said that every system is perfectly designed to get the results that it gets. And what we saw was a healthcare system in the United States that was built around volume and pricing and was centralized around services in very high-cost centers, hub and spoke systems that brought patients into the highest priced parts, usually a hospital system. Healthcare was, at that time, extremely costly in our region and across the United States. And in fact, the United States government had made a clear indication that it would bankrupt the payment systems that we had. Much of what we saw was there was a radical difference between inpatient and outpatient pricing, and that the major hospital systems in a region could demand much higher pricing that it could then pass on to raise pricing in other settings. We knew at the time that much of the care that used to be in the hospital, so when the hospitals first developed, it's where you went for IVs, it's where you went for antibiotics. You couldn't afford to have 3 MRI machines, so you had it at the hospital. It was a place you could keep open 24/7, and it wasn't as pricey as it is now. Most technology and specialties have advanced now so that most things can be done outpatient. And so the ability to sort of keep those things inside a high pricing model is part of the problem that we saw had to be fixed. Per capita spending on healthcare is estimated to be 200% greater in the United States than in other economically developed countries. The number one reason people give for bankruptcy is that they can't pay their medical bills. And that's true in Appalachia, Tennessee, as it is anywhere else. Despite these high costs, the indicators of quality in the areas were low, and traditional models of care were not really affecting that. So we saw that the system as it was fragmenting care, that it could be made better, and we set out on a 10-year quest to do that. A hub and spoke model bankrupts the rural hospitals and takes services out of the areas where they should be given locally. It overestimates the value of providers that are in high specialty centers over the need to have providers that are out in more rural areas. It sometimes underestimates the need for acute care facilities, which need to be very, very close to the people that need them, and wants to centralize that into a hub out of economies and efficiency. So we recognize the need for change to empower the system to move from fee-for-service to fee-for-value. And we recognized it meant the system, the structure of the system, not the behavior of the system. The structure of the system had to change. One of the things that we did early on was we decided we needed a common medical record for all our patients. We needed to know where our patients were in the system, and we knew our patients wanted us to know that. Did you go to the urgent care? Were you in the hospital? And so the physicians, the independent physicians, invested and sponsored basically a health information exchange in our region, which had failed previously under other grant models and sponsorship. Currently, in our health information exchange that we have in the region, we have 80 to 90% of all the data in the region. If you want to know what the data in the region is, you can come to us, if you have permission, to see this kind of data, and we can tell you what the admissions to the hospitals are, because we get those in our data system. If a patient's admitted to the emergency room at our hospital, 1 out of 4 of those patients have data in this system within the prior 7 days. It may be data that they had a CT scan or they saw their doctor. It's very valuable data, and we use it every day in our value-based contracting, but the ER physicians at the hospital don't have it, and the hospital hasn't adopted it. Instead of using a system sponsored by the community, as a matter of fact, since the COPA, they've now decided that they're going to spend hundreds of millions of dollars to build a hospital-centric health information system, which may make our system less functional and less compatible with the value things that we desire to accomplish. We presented a letter in November of 2016 to the Department of Health after the COPA application was filed in Tennessee, which basically said, what's in the application is not strong enough. Not that we're against it, or that we think there aren't good things that can come out of it, but that the regulatory requirements and governance and other areas that were in here were not sufficient to make this into something that we could guarantee that the benefits would outweigh the risks. The hospital-centric governance, financial, operational system proposed in the COPA were weak. The impact of the monolithic monopoly, which in this region it is the biggest employer, as you heard, it has tentacles in everything that happens in our community. It will impact the local economy. It will impact outpatient markets. It will impact the geographic distribution of services, not necessarily based on where patients need them, but based on what's economically efficient for the systems. Maybe we don't need 2 trauma centers, but maybe we need the trauma center in Kingsport. Maybe we don't need 2 children's hospitals, but maybe where the children's hospital is, it needs to be looked at more carefully and not just on financial grounds. At any rate, price transparency and parity, as you heard today, in the outpatient marketplace has to be part of the metric of success. The ability to block or to squat on value, and I get the whole idea that value's something that we need to coordinate, we need to be interoperative and interactive with, and I applaud all the efforts, and I think they can be successful, to bring people together to do value. But we know that historically the financial interests of a company drive its behavior. And it's in the financial interest of these hospitals to drive service lines and work into the hospital where the prices are higher. and to use the hub and spoke models that have traditionally been used. CMS, in its final rule this year on medical shared savings programs, specifically noted that hospitals were forming ACOs that were actually blocking the access for patients to get into ACOs that were doing value, because by building those ACOs, those patients would not be attributed to another model. We were skeptical, to say the least, and did not think the application would meet the standard. As an attorney, I went to law school before I went to medical school, but as an attorney, the clear and convincing standard seemed overwhelming to me, and we just didn't think that it would happen. So what's happened since the COPA? Impacting patient care, rushing changes, having things happen too quick. Of all the models that I saw up here today, the one at Phoebe Putney reminded me of what I'm seeing on the ground, which is a lot of confusion in an effort to coordinate between a business and the government, rapid changes on the ground which impact patients. So let me give you just a couple of examples. Shortly after the COPA, we had about 10 outpatient surgical rooms that were operating in town. Those were places that you could take your patients as an alternative to surgery in the hospital. Shortly after the COPA, all of the beds were closed. The center that we were owners in was dissolved against our objections, and when we offered to buy the center so that we could continue the care, that was refused. As a result of that, Bristol went without an open surgery center for quite a few months. Now, eventually, will that get fixed? Yes. Did it need to happen? No, it didn't need to happen. It created bad care and bad experiences, and it was dissolved where there was another opportunity. So we think that it was probably done in order to help them control the outpatient marketplaces. We have a lot of information that may be part of what was done. In Kingsport, the same model will limit rooms, will allow the closure of one of the surgery centers there, and will bring other players into the marketplace, possibly with higher priced national contracts. CON law adjustments in the COPA will eventually, hopefully, fix this. We were able to go and get a CON. The hospital was not allowed to object to the CON, which was in keeping with the COPA, and I applaud the fact that we were able to get that CON, but it won't be open for a year. So between now and then, it won't be. In the meantime, the hospital outpatient ambulatory surgery center that is there is being restructured to put restrictive covenants on the doctors that are owners there, so that if they leave, they can't be owners in other centers. This type of behavior is perhaps predictable, but is not the kind of behavior you expect from people who are trying to do the right thing. The connection to the HIE in Knoxville, the plan to build a separate HIE, and the HIE in Knoxville won't connect to our HIE. The threatened and the confirmed, I guess, loss of the NICU and the trauma center in Kingsport, bad for patients. It's bad for the geographic region. It will affect the economies in Kingsport. There is a lot of discussion about whether it would have been much better to just sell to an outside system. There's widespread confusion. It could have been avoided. In summary, let me just say, I think our skepticism has perhaps turned to some opposition, but I want to be careful to say that it's in specific areas. I do think the COPA has the potential benefit to the community if it can be regulated and monitored, just like we said in our original. And although what I've heard today makes me even more concerned that it's a bad idea, I do think that there are certain areas. I think we have to recognize that it maintains and empowers an old paradigm. That's a hospital-centric model of care. Perhaps it's the most common paradigm in America, but it's not the future paradigm, and it's probably going the wrong direction in maintaining the status quo. There's no question it will interfere or block or perhaps subsidize and inhibit other efforts that might have been made in the region, because it will become the dominant place where people look for change, and there's a lot of other players in the marketplace that can bring change besides the hospitals. I believe that it will fragment between hospital-based and non-hospital-based providers. It creates an economy of scale, which which can change really real estate. We know our leases are changing immediately after the COPA. The hospital's moving things into buildings that it owns rather than leasing from other places. So there's a lot of financial need to make this money to reinvest, I suppose, that they do the things that they plan to do, which is create economies of scale. At this point, it appears that the risks outweigh the benefits of the COPA, and we'll have to see if some of these things can be addressed. So those are my comments. Thank you.
Thank you, Scott. Now I will ask John, can you describe Anthem's experiences negotiating with Ballard Health since the COPA was implemented, and whether this differs from the COPA before the COPA was issued?
Sure, I'm glad to. Let me give a little bit of background first. My area contracts across the entire service area in Virginia and then 1 or 2 contiguous counties that are border the state of Virginia. In addition, we own an AmeriGroup plan in Nashville that services Medicare and Medicaid membership, inclusive of Northeast Tennessee. So we have a very, very vested interest in Southwest Virginia and Northeast Tennessee. It is extremely important to us. We are the largest payer on the commercial side in that geography. So when the COPA came to light, we were very focused on it. There were 7 counties and 1 city in the state of Virginia that there would be no other alternative. As it was alluded earlier, I mean, this geography is 14,000 square miles without an alternative, with a geo-monopoly. So this really got our attention, and we were very, very engaged. And we thank the FTC for their engagement with us and the investigation of the COPA process. We share many of Dr. Fowler's concerns and observations. Before, there were 2 health systems serving this geography. Mountain States had a 59% market penetration. Wellmont had a 41%. So there were 2 viable alternatives in this geography. Something that we brought up in December of 2015 in an affidavit really focused on the unintended consequence. And one of those unintended consequences, which was of particular concern for us, were around hospital-based physicians. And by that I mean radiologists, anesthesiologists, ER doctors, NICU doctors, pathologists. Because often what happens within a given hospital, they will give exclusive rights to those hospital-based physicians for those services in that facility. Well, what we have found with Ballard is that it's a geo-monopoly granting essentially monopoly services for those hospital-based physician specialties I just described. And in fact, we're dealing with an issue now. The one ER group in the state of Virginia that is not participating with Anthem at the current time is the ER group that services Ballard. So that is of extreme concern for us. That has taken things front and center, frankly, in our discussions with Ballard. And we really need to work through this and this issue before we can engage in others. We were worried that it was come to fruition 2-3 years ago, and it has. So that is of utmost concern for us. The fact that there's no competition within 60 miles of Bristol is worrisome to us. The fact that there's no tertiary hospital competition in a broader area than that is also worrisome to us. And really, consumer choice, which is so important, that really doesn't exist in this geography. Dr. Fowler mentioned value-based contracts. We have a huge focus on contracting with independent physicians. We have a physician-centric oriented model around value-based contracting and improving outcomes. And not enabling physicians to have a choice of where they send services is very detrimental in those models. For example, laminectomies previously could have been done at a Wellmont facility, and all of their back surgeries may have been done at Mountain States because the outcomes were better. That dynamic no longer exists, and that's problematic for us, and it's problematic for our customers. A lot of national accounts, large group customers, they're extremely interested in these models. They've seen it work across the country. They want it in Virginia. And that portion of the state, an important portion to us, that's hard for us to do now. That's very challenging. We do have another incentive program, our Quality Insights Hospital Incentive Program. 95% of admissions in the state of Virginia take place at a QHIP, the acronym, participating hospital, over 800 hospitals across the country. So we have benchmarks from 2015 through 17 for the 10 ballot hospitals that are in that program. And we will continue to watch and really monitor their performance in that program going forward, as we do with all hospital systems. And then, I guess in closing, finally, something that worries us as well, and Dr. Fowler also alluded to that, the movement of services back into the hospital setting. You had mentioned the AMP-Surge centers. They're often less expensive than the outpatient arena in the hospital. But we're also worried about things like drug, lab, some imaging services, and having those services flow back into the hospital setting at much higher rates. And then finally, we discussed the compounding effect of certificate of need in conjunction with COPA. That's such a challenge. I mean, COPA grants essentially a geomonopoly, and then you have COPN on top of that, which restricts more barriers to entry. It restricts others coming into that market to help alleviate that competitive environment.
Thank you, John. Dan, you've heard our last panelists, Scott and John, speak about their initial experiences as a healthcare provider and as an insurer. Can you describe some of your observations of the Ballot Health COPA, as well as public reaction to the COPA?
Sure. Thank you, Goldie, and thank you, Stephanie, and the FTC for inviting me to participate in this panel. I wanted to give you a little bit of background about me first before I answer the question. I've been in healthcare as a provider and as an administrator for 30 years now. My original training is an occupational therapist and certified hand therapist. I actually have been in Northeast Tennessee for 23 of those years, and I have the privilege and advantage of sitting on many local organizations' boards. I've also sit on the local advisory board for the COPA. I do want to make sure that everyone understands that I'm not here representing the Tennessee COPA Local Advisory Council or any of those organizations that are in my bio. I'm here as a consumer and advocate for the people of Tennessee. I've been following this issue since March of 2015, even before the April 2nd announcement of the merger. I was given some information concerning the COPA law changes. I watched and listened and participated in emergency rule changes that were held by the Tennessee Department of Health. I attended and participated in the COPA Index Advisory Group, which was a group of citizens that were brought together to help form the index, and many of the things that have already been discussed today, like changes to CON, physician caps, those types of issues that people in the community felt were important to be put into the COPA, into the certificate. I also attended and spoke at every COPA public hearing during the process. And in September of 2018, as I have alluded to previously, I was appointed to the Local Advisory Council by Dr. John Dreisner. The Local Advisory Council, and the information I'm giving you, all of this information can be found on the state's website. It's all public information. But the Local Advisory Council really has no regulatory supervision of the COPA. Quite simply, I explain to people that our goal is to be a conduit to the public, to the Tennessee Department of Health and AG's office, to gather information and to relay that information to the departments. The main purpose of the Local Advisory Council is to recommend to the Department of Health how those funds are spent. The money that's was described by Mr. Cowart. Also, we hold an annual listening session, and this year that annual listening session was held in February, and we got quite a different type of reaction during the listening session that I'd ever experienced on anything else prior to the COPA being awarded to the health systems. We had about 40 speakers at that listening session. All 40, with the exception of one, gave very negative comments about what had happened since the Certificate of Public Advantage had been awarded. People were able to give written and verbal testimony at that hearing. We had several municipalities, Scott County, Virginia, Sullivan County, Tennessee, Hawkins County, Tennessee, actually put together this, which they were in opposition of the downgrade of the Level 1 Trauma Center and the downgrade of the neonatal intensive care unit in Sullivan County. Of the 40 speakers that attended the meeting and spoke, most were concerns over the Level 1 trauma and NICU closing. There was also a great deal of discussion about ongoing nursing shortages in the hospital and care, diversion of patients, not because hospitals were full, but because hospitals didn't have the staff to keep those patients in the hospital. Long waits in the emergency room, holding areas in the emergency rooms where patients were being held, not again because the beds were full at the hospital, but because there was no staff to take care of those patients, and floors were closed in the larger hospitals in the area. Staff physicians actually came forward. These were physicians that had been on the Level 1 Trauma Center and discussed that some of the changes that were occurring, that they had no input into those changes to the Level 1 Trauma Center. EMS and nursing professionals came forward to talk about the impact of the loss of the Level 1 Trauma Center in Sullivan County and the significant burden that this would be placing on the people of Southwest Virginia. I did want to talk briefly about some of the things that were also described earlier, especially about CON and independent doctors and how CMS looks at independent physicians. In December of this past year, CMS on their report for accountable care organizations actually recommended that there would be fundamental changes to how ACOs are run because independent physicians were outperforming hospital-based physicians on cost and quality pretty significantly. The cap on physicians has been something that has been discussed on several meetings. It's been discussed among local advisory council. I've also participated in phone conferences with the Tennessee Department of Health as to what is driving physicians to hospital settings. I believe that CMS, Department of Health and Human Services, U.S. Department of Health and Human Services, are in agreement that consolidation of healthcare systems and consolidation of physicians to hospital-run organizations not only increases cost, but it decreases access to care. That those are things that have been discussed very recently over the last several months, and I see those as being big barriers to the continued quality of care in Northeast Tennessee. I also have heard from a community standpoint several times that we're coming up on a very big milestone where the health system will be able to fully integrate their resources at, I believe, at 18 months. And I guess one of the things that we keep hearing in the community, if there's so many things up in the air, or if the healthcare system is struggling so much to get everything in place that it needs to get in place, that maybe the Tennessee Department of Health and the AG's office may want to delay the full implementation of the COPA until we have a little bit more certainty as to whether or not this is going to be a clear and convincing evidence of public advantage. Thank you.
Thank you, Dan. And last is Erin. Dick, if you could pass down the clicker for Erin.
Sure.
She'll need this for her opening remarks. By going last, Erin, you benefit from hearing from all the panelists. From your perspective as an academic, what are your observations on the challenges that state regulators face when establishing COPA regulatory regimes? Does the retrospective empirical research presented this morning factor into your impressions regarding recently approved COPAs?
Thank you, and I'll echo my fellow panelists' gratitude to the FTC and to Goldie and Stephanie for organizing this event. I think it's really been terrific and an incredible opportunity to hear from so many different perspectives, to hash out what seems like this narrow issue, but it has much larger implications for the larger cost and the future of the delivery system of healthcare in the country. So the way again, just a quick background, why am I here? Everyone else is it's clear why they're here on this panel. I'm a law professor, so I don't do COPAs, I don't administer them, but the reason I'm here is that the Milbank Memorial Fund commissioned 2 reports that I wrote. One was a really deep dive into the Ballot Health COPA, just sort of documenting the process, the approval process, the statutory authority, and then kind of coming up with some policy implications, which I'll touch on here. And then I did a follow-up report, just a shorter report on reflecting on what do we learn from the Mission Health experience, and what information can we glean from there. So that's the perspective I bring. So policy implications, the policy implications that, hearing today's presentations, this is sort of echoing what I came up with in my report. So in some ways, my thinking is enriched today than just what was in my report. But I remain, convinced that there are certain takeaways, to the extent that, Professor Daphne said, if you've seen one COPA, you've seen one COPA. I think that's true, and I also think that there are lessons learned. Right? We have all the folks from Kip and Mark from North Carolina and Montana saying it would have really been helpful to know this before they embarked on COPA, and even our experience, Tennessee and Virginia are improving the COPA process and really putting a lot of thought into it, building on what has gone before, but there is still more to learn. So one of the takeaways is that COPAs are incredibly resource intensive. This is not it's not a light version of regulation. It's complete regulation in a region. So instead of statewide rate regulation, it's rate regulation, quality regulation, access regulation, population health regulation, all rolled up into one, but it's focused on a region instead of on a system instead of on the whole state. So COPAs can be, and I think increasingly we're seeing where states are thinking of pursuing a COPA are areas like what we see in Virginia and Tennessee, rural populations or semi-rural populations that struggle with their health status and health statistics. And I think that is a driving factor of what's kind of, it's not that everyone thinks that this is the best case scenario. If you could design a perfect system, a COPA would not be it. But when you're facing the population health struggles of these rural areas, I think that there's few options left. And so a COPA feels like it's a way to allow some of the resource consolidation without losing some of the ability to extract those population health commitments. Coordination is key for a multi-state COPA. I think Janet and Joe made a great point about that. I'm not going to go into it further. I think that they illustrate entirely why coordination is critical here in a multi-state situation. COPA conditions, as we've heard throughout the day, there's this tension between wanting the initial COPA terms and conditions to be incredibly detailed and incredibly enforceable and specific, because this is the moment where there's negotiating power, everyone's excited, but everyone's also very concerned. There's the most motivation that there'll probably ever be in the whole process when you're entering into that initial set of terms and conditions. However, it can't be so rigid that as the system changes, as dynamics and payment reforms roll out and the health status of the region hopefully improves, that those COPA conditions can't change as well. And so it's not about necessarily going all the way up to the legislature or even getting a new rule passed, although sometimes that's necessary. I think a lot of it can be done in this sort of the terms and conditions negotiating. That's more nimble. And so I think in some ways the states, by being so involved, can bake into revisit the terms and conditions of the COPA over time to get that flexibility, but also that, keeping the enforceability of sort of hard, say price obligations, for example. And the last two I'm going to go into a little more. States must define what a successful COPA looks like to them, right? They have to know and keep very clear at the forefront of their mind what it is that this whole enterprise is setting out to do. And because they are so risky, because it's such a risky undertaking, the state has to really commit to remain vigilant, not for 10 years, not for 20 years, but forever, for in perpetuity. Once you grant that monopoly, unless new competition enters the market, if you have a monopoly, you need a COPA. Right? You need oversight. Unless there is other competition, there isn't, the other option is an unregulated monopoly. So I think in some ways, what Tennessee and Virginia have done, they have the resources, they have the capacity. They've taught us that, in some ways, it's there. If anyone is poised to do this well, it's Tennessee and Virginia. I think they've done an admirable job. And at the same time, the empirical research, based on what we've heard, it's possible that well-equipped states who have data, who have the resources and the capacity, which both Virginia and Tennessee have the possibility of constraining cost growth, of maybe even measuring and keeping a thumb on quality and listening to the community. That said, so it's possible that there could be strong COPA oversight and that the net benefit is achievable. There is also a very high risk that the COPA will be, that all of this enthusiasm, it's sort of like a prenuptial agreement. Like all of this enthusiasm is there on day one. We're still in the honeymoon phase. Everyone's still excited. Everyone's still in love. But 30 years from now, it might be a completely different story. And so how do we build in, as Janet mentioned, those sorts of survival provisions or a plan of separation that is actually actionable, to force potentially divestiture? If things start to go south, the state needs another option other than just unregulated monopoly. And so I'll just speed through these. This is sort of, again, this is my 30,000-foot bird's eye view, not particularly steeped in the day-to-day, but what does a COPA look like? What are we setting up? What are the red flags? If a state were to encounter significant closure of rural facilities among the COPA entity, that would be a red flag, that something is going wrong. The initial commitments from ballot last for 5 years, and so to revisit those over time. Maintenance or improvement of access to key services. How do we measure maintenance of access, improvement of access? Is what's going on with the NICU and the trauma facility and the ambulatory surgery center, does that rise to the level of a loss of access? And how do we know when we're losing access to key services for the population? Price increases and spending in line with more competitive markets. In some ways, this is what the economists are very good at measuring. It seems like we have models, we have data, and I think it sounds like we need to get outpatient data as well. Maintenance and improvement of quality and over quality metrics, I think that's critical. But of course, going outside of just the four corners of the hospital, it's not just inpatient quality. Yes, we don't want that to decline. But the population health in general has to also improve. Otherwise, again, once an entity has been granted a monopoly, it has taken ownership over the population health of the entire region. And so looking sort of at those upstream measures as well. And so when states, the admonition is just that states must remain incredibly vigilant. And I think that, the systems that Tennessee and Virginia have built, the indices, they really do touch on all of these dimensions: price, quality, and access. The main concern that I would have is just how do we resist the incentives to evade or repeal the COPA oversight 20 or 30 years from now? How do we avoid what happened in North Carolina and in Montana, in Virginia and Tennessee? Once, 20 or 30 years from now, like these officials and their collective institutional memories will potentially have moved on. And so that there's no, how do we build in that commitment to be in perpetuity and understand that if ballot is performing well and is being a good actor, that is not a reason to remove the COPA. That means the COPA is working well and that should stay in place. Detailed and updated plan of separation. Again, I don't even know if this is a possibility, but as much as possible, maintain the possibility of a separation. Because if the COPA oversight disappears, then there has to be a way to at least restore some modicum of competition. And then, again, building that resource and capacity for oversight and in perpetuity, emphasis on in perpetuity. Until there's no longer a monopoly, there needs to be a COPA. There needs to be oversight. Whether that's in the form of a COPA or some other state oversight mechanisms. We'll hear more about that in the next panel. There has to be some level of oversight because you either have competition or you have regulatory oversight. You can't have neither. And that's, I think, what the takeaway from the empirical studies this morning told us.
Well, thank you, Erin. I have several questions to pose to the entire panel, and to save time, I may cluster a few of them so that we can save some time. But Ballard Health been meeting the state's terms and conditions so far? Are there known instances of Ballard Health not meeting the state's terms and conditions? And are any amendments being considered to either Tennessee's terms of certification or Virginia's order with conditions?
So I can speak on behalf of Tennessee's terms of certification. To date, yes, Ballard has met all the requirements under the terms of certification. We've had one or two very minor instances of noncompliance that were actually reported by Ballard, immediately reported by Ballard, along with a corrective plan of action. And those corrective plans of action were implemented, and we have confirmed that they have, in fact, done everything that they said they were going to do. So in terms of their just regular ongoing compliance, that has all been met. With respect to discussions about amendments to the terms of certification, I think this is probably reflected in both the COPA Monitor's report and the Department's annual report, that there are, one of the big areas we are looking at is population health. If you compare the index, the sub-index for population health in the Tennessee's terms of certification with the Virginia order and their conditions, you'll see a big disparity between the two. Tennessee has somewhere in the neighborhood of, I believe, 52 measures that we are measuring in the population health index, whereas Virginia has significantly less than that. And there has been considerable discussion with Virginia, Tennessee, and with Ballard about looking at that index and maybe narrowing some of those indices. The concern is that if we try and require Ballard to meet all of those, we won't meet any of them. And particularly given the success that we have seen to date in creating the affordable care community that Ballard is standing up, we want to make sure that we're not doing anything with the population health index that is contrary to or that is going to actually be an obstacle or impediment to the work of the accountable care community. So that's probably the biggest area. The other area is in Addendum 1, because it is currently set up as a retrospective look at pricing. And we have no intent upon changing it, particularly since we've only been in place for 16 months. But we do want to look at it to see if retrospective is the best way to be testing the pricing, or is there a better way of testing it. So that's really more just of an ongoing process that we are reviewing with our experts to make sure that we are utilizing the best format to put in place those pricing controls.
In Virginia, there haven't been any confirmed non-compliance events under the Virginia order. Our cooperative agreement staff do review complaints and have reviewed complaints that were submitted alleging violations of the commitments and conditions of the order. However, thus far, our investigation of those complaints has not revealed any violations of the Virginia order.
Yeah, and I think my comment would be we are in compliance, and one of the self-reported kind of footfalls here was that in post-acute care you're supposed to give the discharged patient a list of their options, and we did it for the county but it was supposed to be for the county and every contiguous county, and we found out later that it was just the county, and so we corrected it and self-reported ourselves, And so otherwise, I think we're in a very active discussion with the state about how to do this right, and are engaged quickly with them. I think the other thing we found, and I think the state has seen this, is that most of our complaints have nothing to do with the COPA. Just like we heard from Montana, all of a sudden every business issue becomes a COPA issue. What Anthem just referred to is an emergency room group that is building out a network. That's happening in every city in America today. And the physician group that's doing it is doing it in every city in America without regard to the COPA. It has nothing to do with the COPA. And there can be any number of things. Wait in an ED. Wait in an ED. People want to be seen immediately. They put in a bill on giant billboards in Nashville. It's going to take you 20 minutes. When you walk in the door, it takes 12, and they're upset. That's going to happen. So we get that. They've all of a sudden, and so they go through our COPA complaint log, and they see that these are kind of normal things that are going to happen. They're not related to any of these terms and conditions, but we understand they are patient satisfaction, and they are important, and we deal with them in the normal course, but not as a compliance issue.
I would argue that the ER situation, it is impacted by the COPA because you no longer have two alternative health systems. You've got one with one essentially ER group. Had that happened in the past, members could have gone to Wellmont or they could have gone to Mountain States and seen a in-network ER doctor. So it is not a compliance issue relative to this specific conversation, but it is definitively an outcome of the COPA and the granting of essentially a monopoly within a monopoly.
I think also, sometimes I think we get caught in the weeds as to what's officially a compliance issue and what's not. There are some unintended consequences, and when as a community you're told during the process, the 2015-2016 process, that the COPA is necessary to maintain local control, reduce cost, and improve quality. And it may not be a quote-unquote violation of the COPA, but when cost increased with no evidence of improved quality, I think that does, at least go to the spirit of the COPA and the certificate. And there are several examples of this happening right now in Northeast Tennessee. We had an oncology outpatient, Dr. Fowler mentioned, and John also mentioned the fact of movement of services from outpatient settings to hospital settings. Hospital settings are the most costly settings to provide care. In real simple terms, if I'm an oncology patient and I have a commercial payer as my insurance company, going to an outpatient facility, I may have a copay of $20, $30, or $50. If I go to and get that same type of care at a hospital setting, I have a facility fee. But also, as important is my policy doesn't cover that as an outpatient services, so I have to pay 100% up to my deductible or a co-insurance of 80-20 until my deductible's met. So instead of $20, $30, or $50 for that payment for the oncology services, I may have $160 worth of care for that day. And I think also what happens when, and Dr. Fowler mentioned this briefly too, when you shut down every ambulatory surgery center in a town, Bristol, Tennessee, and move those cases to an outpatient, even if it's hospital-based outpatient services, on average you're paying 60% more. That's the payer, that's to the commercial insurance, that's to the Medicare, that's the Medicaid, and if you're a commercial paying patient that has a high deductible health plan, you're going to pay 60% more for that. We also have a situation where there's been a sale of some of the assets of ambulatory surgery centers to an outside entity, and it's widely known throughout the community that part of the reason why that was done was so that they could then access higher national contracts. So again, it's a way of kind of gaming the system. We heard discussion about that from the folks from Montana in the earlier panel discussions, but it's something that's increasing the cost of care and is certainly not local control of that care.
The questions that I had planned to pose, I think you had started to address, Dan, as well as Scott and John, in regards to the circumstances that may have popped up due to the COPA. But are these circumstances that you described unique to the COPA, or are they generally applicable to other COPA and COPA regimes going forward? Is this an area where future states should consider?
Well, I think I've suggested that maybe there's some areas that we need to regulate in the current COPA that we're not, or at least it appears that we're not. One thing I think is when you have a COPA that's like this isn't a 2-to-1, this is 2 systems to 1. I mean, this is an unprecedented type of arrangement that literally will affect every bit of every economic decision that gets made in these 3 little cities. And they are almost 1 million people, so it's not insignificant. It's the entire population of Montana that's being affected here. I think regulation of what happens between the inpatient and the outpatient market in a place where an inpatient COPA or inpatient monopoly has been granted has to recognize that monopoly can create vertical monopolies inside. And it can go to home health, it can go to lab, it can go to surgery centers. These surgery centers would have never been closed if it wasn't for the COPA. They're competitive moves in the outpatient marketplace by a competitor in the marketplace that now has a monopoly in the inpatient marketplace. So I think in the future we should have recognition of that, and maybe even in the present we should have more active supervision of what happens in the outpatient marketplace. Yeah.
Well, that leads to a question on the future. Does the panel have any reaction to the empirical research presented during today's morning session? Does anyone have any thoughts regarding the possibility of the FTC conducting a study in the future on the impact of the ballot health COPA and once more data becomes available?
I think that it's not just a good idea. I think it's imperative that this be studied.
I would say the opportunity to prospectively now, because we probably can go back. This COPA was, it was thought of years before it actually became a COPA. During the period between the time that it was first proposed and the time it became a COPA, behavior did change between the hospitals. So even though they were going about their business, there was behavioral change. I'd like to, carry the study back far enough to really get legitimately understand what the market was like when they were competing, and then prospectively carry it forward. That would be awesome.
And from a payer's perspective, and I'm sure Anthem is not the only one, we're going to look at the performance in our pay-for-performance programs. I mentioned the Quality Insights Hospital Incentive Program. We've already got a baseline, 2015 to 2017. We know the performance of the 10 hospitals that participate in that program. And we are going to be looking at that going forward, as we do across our entire networks. Our customers are asking for that kind of feedback.
And I think it's important to not focus solely on inpatient prices. Of course,
exactly.
that will be very important, but you can't get the impact on the value-based purchasing or on the outpatient dynamics that you're describing if you only study the inpatient prices. And I think also the total spending, because, again, moving more people into higher cost settings will be reflected in those types of total spending analyses, as opposed to just focusing on the effect of the COPA on inpatient prices.
Totally agree. So our program has 37 metrics. NCQF, National Quality Forum, Society for Thoracic Surgery, ACC, American College of Cardiology. So it's not Anthem dictating these measures. These are independent third-party measures for all places of treatment, inpatient and outpatient. And that, you're exactly right, that's extremely important to get the whole episodic view of the cost of care and outcome, quality outcome.
I'd like to offer perhaps another view, is to say that, the three ones that we've been talking about today, we've, in West Virginia has been barely talked about, but is that, we've got, in healthcare terms, a couple of cadavers and a baby. And so we've got some, the ability to study something that's 15 months old. We've literally renegotiated one payer contract in 15 months. And so with all the activity that at least we have to do on what we hope is our noble mission to deal with this, to say, well, let's get a CID for 1 million documents so we can say that the federal government studying this is I think bordering on irresponsible, frankly. And so I think that the ability to kind of continue to watch and monitor, have panel workshops. We are being actively supervised, but if the thought here is that we're going to do a pseudo investigation by calling it a study when we have complied with everything that's constitutional and legal, I don't think that would be right.
So I'll speak from the state's perspective here, or at least from Tennessee's perspective, because our COPA statute applies statewide. And some of the issues and some of the reasons why the COPA was ultimately approved in Tennessee exist elsewhere, not to the degree that they exist in Upper East Tennessee. But Tennessee leads we only second to Texas do we lead the nation in the number of rural hospitals that are closing. And the vast majority of the counties in Tennessee are classified as rural counties. And the health of the state of Tennessee, if you look at the health rankings, we're usually in like the bottom 10%. That's only multiplied by multiple factors in Northeast Tennessee. So from our perspective, contrary to what you might have heard from some of the panel participants, this was not an easy decision for the state of Tennessee to make to approve this COPA. It was a very, very difficult decision, evidenced by the fact that it took us almost 2 years to actually approve and issue the certificate. From our perspective, the more information that we have, the more analysis, the more empirical data that we have as to the effectiveness of the COPA, and not just from a pricing perspective and not just from a quality perspective, but from how have we actually been able to improve the health of the population? How have we been able to improve access to health care? All of the factors that are listed in the index by which we are testing this COPA, the more information that we have to help us go forward with the next application that we may see, we think is entirely beneficial. But we do think it needs to be a universal testing study and not just focusing upon one aspect, just focusing on pricing or just focusing on quality.
And I would concur with those remarks from Janet. Definitely was not an easy decision. It was not one that was entered into lightly. It was the result of many, many hours, months of work by many people. A lot of good comments today, and I would definitely echo Janet's remarks about the importance that we placed on population health improvement in the region as part of our overall review and analysis of the COPA and of the cooperative agreement. And one of the statements that I heard during our review process that really has stuck with me ever since then was actually from one of our local health directors in Southwest Virginia, and this person wrote to us. She said, "The strong competition between the applicants has failed to provide meaningful, visible benefits to the people of Southwest Virginia in terms of access to care and improvement in health status." So not to denigrate the competition in any way, but we were hearing alternative views that again speak to the complexity and difficulty that went into this decision.
Well, thank you. Thank you all. Due to time, I can't go through these wonderful questions that the audience has posed, but my sincere thanks to the distinguished speakers on this panel for agreeing to speak today, despite having such busy schedules. I also thank you all for attending and live streaming our discussion this afternoon. There will be a 10-minute break before our next panel, which is entitled Policy Considerations for COPA's Competition, Wages, and Beyond.